The thing is that the topic given to me was very, very wide. It's very, very wide. So I've tried to keep it. I thought that probably ear cancer would be covered with heart stop, so I just dropped that. I haven't included thyroid because that is a completely different thing. And as far as tongue carcinoma is concerned, it's the MRI. Basically, it should be MRI. So things which can be evaluated best with CT scan, I've taken up that. And majority of those things, they are the midline structures. Okay, so the objective of this was to explain the rational use of CT scan in malignancy of nose, paranasal sinuses, oral cavity, pharynx and larynx, basically the midline structures, the epithelial problems basically. And secondly, the more important thing is that, well, first of all, the disclosure, there is no conflict of interest. It's not a funded presentation. Source of images are mostly old record and internet, non-copyrighted images. Okay, so we are starting with from top to coming down to SINO-NASAL region first, then the pharynx, then the BUCCO-ALVEOLAR region and the larynx. So it's going to be quite a crowded sort of images sometimes, but I've made this slide short so that I can speak more. First of all, to start with, first of all, you must know the normal anatomy. And for understanding the normal anatomy, you must look at the normal scans as much as possible. When I started radiology, my mentor told me that when you will look at 1000 normal images, then you will start identifying the abnormal. And that was very, very true. The more you see, the more you learn. So this particular image, okay, so the greatest help that we have is that again from nose till the larynx, the anatomy is symmetrical. So what you have to do is to look at the symmetry of both sides. This is the most important thing. Then just try to remember what things are in the midline, what things are of the sides. Look at the midline first. Identify the bony structs. Identify where should be the normal layer and where should be the soft tissues. The soft tissues, remember, are usually a bare minimum whitish line just lining the dense white structures. And always evaluate both the soft tissue window and the bony window. The bony window is the one in which you can see the bones clearly standing out. And the white and soft tissues, they are relatively a blur of grayishness. When you look, you have sometimes, there are times when you have to compromise between both the windows just in order to get highlight or accentuate some sort of calcifications in the soft tissues. So that is another thing. And please try to look at the three planes. The axial, okay, the one on the right side, the one on this side is basically the axial image. Okay, axial में अपने center is the central septum. On either side of it are the ethmoids. Even far more laterally are the maxillary when you go down. And in the center, what you are seeing anteriorly most, within the bone is the frontal sinus. As you go down, you go posteriorly, near the aerodigestive tract is the sphenoid sinus. This is just the basic topography. Now extrapolate this on the coronal image as well. Again, central nasal septum, the sinuses, the nasal cavity, Outwards are the maxillary entra. Superiorly is the sphenoid sinus. So look at these things. Try to imagine where are these structures are normally located. This is very important in identifying this. Now what help we get by these two particular images, the coronal and the sagittal. In coronal, you can see the nasolacrimal duct beautifully. When you go from anterior to posterior, you can outline where is the nasolacrimal duct presenting. And in the sagittal sections, you basically identify the ethmoid recesses, the frontal recesses, and the sphenopalatine recesses. They are outlined beautifully. All you have to do is to remember frontal is anterior, the ethmoids are somewhere in the middle, and then the sphenoids are posteriorly. So look at the connections between these things. These fine canals which are communicating with each other, they indicate as to where are the... Okay, sorry for this grand slide. I just shown you the normal anatomy first, but then now we are coming to the... If you can see that nose and paranasal sinuses, when our CT was intact, my 50% work was used to be head and neck malignancy. It was such a great burden of head and neck malignancy here that I was sure that if I'm reporting 15 cases, at least 7 cases would be somewhere of either the BUCCO-ALVEOLAR CA or some nasal problem or some ear problem. Now, all sort of abnormalities, all sort of malignant tumors can happen because there is the mucosa, there is the bone, there is the cartilage, and there are nerves and vessels going along. So all sort of tumors can be there. But please, my own concept was that if I am seeing a tumor, if I am seeing something asymmetric, irregular, heterogeneously enhancing, which is definitely eroding the bones, it's more likely to be tumor rather than the infection. Maxillary sinus is the most common site of tumor. What we know is that you can make a lot of diagnosis on clinical features as well. What is required for required from the CT scan is the anatomical extent of disease, so that you can make a pre-operative plan and you can plan your malignancy. So coming to I'm taking up the commonmost malignancies. First is the SINO-NASAL carcinoma, a very, very common malignancy. Contrast enhanced is required, number 1. No HRCT, no thinning, no plain scan, please. Contrast enhanced CT to begin with. Then you should keep the differential diagnosis. It is done, number 1, to exclude differential diagnosis. Because an aggressive, chronic, invasive sinusitis can mimic tumor. Then there are times when fungal sinusitis is very, very difficult to differentiate sometimes. The third is venous granulomatous. That is another different and sometimes confusing differential. So number 1, you have to decide whether it's SINO-NASAL carcinoma or not. What are the anatomical landmarks? Anatomical landmarks are obviously the buccal tissues, the pterygopalatine fossa. अरे भाई मैं बहुत जोर से प्रेस कर रहा हूँ मुझे पता है मैं जोर से प्रेस कर रही हूँ Okay, so pterygopalatine fossa, and then you have to look at the maxilla. This whole is the maxillary bone. You have to look at the palate. You have to look at the neural phenomena. Where would they be located? Okay. So what you basically see is a soft tissue heterogeneous density mass, which is heterogeneously enhancing. Bony destruction, to know the extent of bony destruction is very important. Bony destruction is best identified on the bone windows. What is important is if you are looking at only the posterior or just slightly anteriorly, this is a T3 lesion, T2 lesion. But if it is going posteriorly and superiorly, then this is a T3 lesion. This is just a very, very small tip. It's very handy. Anterior है, anterior posterior है, अच्छा ठीक है. Something like T2. अगर ये erode कर रहा है posteriorly, then superiorly especially, तो ये T3 तक जा चुका है. And if it is extending into all these adjacent areas, if it is extending into all these adjacent areas, it is going into cranium, it is extending these areas, then this is T4. Straight away. Okay. So this is a very, very small tip, but usually comes up handy. Okay. Now another very important point is non-Hodgkin's lymphoma. I distinctly remember that people usually avoid biopsy, but biopsy is very important whenever it is considered, because if it is Hodgkin's lymphoma, non-Hodgkin's lymphoma, then it would be, then you can save your patient from some mutilating surgery. So this is very important. Number one, Hodgkin's lymphoma is usually associated with much larger lymph nodes, and the involvement of more nasopharyngeal involvement is more common with it, relatively. Secondly, the pattern of bone erosion is less like destruction, more like pressure erosion. This is one very practical point that comes up with practice. If you can look at okay, so look at this. This looks very aggressive lesion. Something which is extending up right up to the back of the nasopharynx. Something which is remodeling. It's not actually destroying it. अगर आप पिछली स्लाइड याद करें, so it was more like a destruction. बीच में एरियाज थे ही नहीं बोन के. This is something which is gently pressing on the bones and causing it to become thinned out. That is called erosion. So pressure erosion due to the presence of something, a mass rubbing on the walls, has a different appearance, and something which is actually eating away the bone has got a different appearance. And that is important to identify. But again, it is again a mistake to depend everything on radiological appearance only. Please go for biopsy. Number one, you have to differentiate whether it's a differentiated or undifferentiated carcinoma, whether it is an adenocarcinoma, or whether it's a lymphoma. So these are very important point to have a biopsy anyway. Now coming from there, coming from SINO-NASAL area down to pharynx, again a cramp slide, but just I have placed these three things together so that you may see the normal gentle difference between the nasopharynx, the oropharynx, and the hypopharynx. So when we talk about nasopharynx, we are basically talking about the area behind the posterior cranium. ठीक है? Extent कहाँ तक होती है इसकी? What is the definition of nasopharynx? Where does nasopharynx end? Palate. ठीक है? Yes, till soft palate. Below that, it becomes oropharynx. ठीक है? और oropharynx के बाद start हो जाता है epiglottis के level पर hypopharynx. The thing is, ये हमने अपनी arbitrary divisions बनाई है. There is no soft tissue boundary, there is no fibrous thing, which is actually a border which is closing off these limits. They are all continuous boundaries. So what basically I want to impress upon is that the pharyngobasilar fascia, which is starting from the base of the skull and going down to the hypopharynx, is basically should be a very thin line. It should not be this thicker thing. see, problem with nasopharynx and oropharynx is that there is such a large space. It's an aerodigestive tract, and there is such a large space to expand before the symptoms become visible that we often come across these lesions when we are looking for an occult primary. This is one very important thing. Sometimes when there is no occult primary and these are the maps of squamous of some carcinoma, then we are looking and then we feel, oh my god, there is this mass in the nasopharynx or the oropharynx sitting posteriorly. So this is very important. Again, there is a very detailed staging classification. What you basically have to identify is that, remember that these are very vascular areas, and there are vessels nearby. It has a very good lymphatic drainage. The result is that a nasopharyngeal CA, when it becomes manifest, 90% of them have enlarged lymph nodes with them. When oropharyngeal CA, usually you see something in the tonsillar fossa. Again, sort of a long-standing sore throat, something coming up, patient not quite understanding what's happening, but there are lymph nodes. Patient is being evaluated for lymph nodes. 60% of them present with lymph nodes. And then what you see when you do a CT scan of the neck, then you see this mass sitting usually in the tonsillar fossa on one side. Again, it's the comparison of symmetry which is important. The narrowing, the percentage narrowing of the aerodigestive tract is important. Erosions are important. This preservation of adjacent fat is important, and even more important are these vessels. On contrast enhanced CT scan, there should be, always look on the normal side, the thinner side. I would identify the normal side by which side is thinner. So if there are whitish structures on this side, then there should be whitish structures on this side as well, like this. Why? Because these represent the vessels, intact vessels. And from there you decide if the tumor is extending around them, if they are clearly visible or they're completely absent. Like one case that Fahad showed, I was just wondering where are the vessels gone? वो जो malignant otitis externa के देखा था, I was wondering कि इस side की vessels कहाँ चली गई? So you have to wonder कि ये जो vessels हैं, ये whitish dots, 3 whitish dots इधर भी हैं और इधर भी हैं. अगर ये white circles नहीं है, then this is dangerous. किसी भी side पे नहीं है. Secondly, all this thing should be very black. But the beauty of CT scan and the goodness of CT scan is that I'll show you. I've kept a MR picture just to show you the neck, that why I prefer CT over MR in these cases is that the CT is black on CT, fat is black. So the natural fat provides natural background, natural contrast, and you can identify if something is abnormal in between. So if it is a clear, plain fat, it's very good, like this. But if there is something grayish in between, then this is an enlarged lymph node. Should be ideally be very clean and clear like this. ठीक है, ये आप लोग नॉर्मल सीटी जब देखना शुरू करें तो उसमें हमेशा ये आइडेंटिफाई करना करें. अगर छोटी सी भी व्हाइटिश ग्रेइश डेंसिटी आ रही है, then look at it. ठीक है, नेक में नेचुरली बहुत सारी सी आपको नॉर्मल lymph nodes मिलते हैं. Again, it's the size and enhancement which is important. This is basically the hypopharynx. Hypopharynx is basically that area of aerodigestive tract which is posteriorly located and leads to the esophagus. ठीक है, जो esophagus में जा रहा है, याद रखिए इसी सेम लेवल पर जो esophagus में जा रही है चीज, that is hypopharynx. जो उसमें जा रही है ट्रेकिया में, that is laryngopharynx. Very simple. एक बिल्कुल common sense और common point वाली चीज़ है. Okay. So this is basically a hypopharyngeal lesion which is extending into the adjacent laryngopharynx as well. As Fahad said, look, when you are confused between where lesion is starting and what is the origin, then look at the epicenter. And epicenter is that place where the disease is most manifest. Like, where do you think the disease is biggest here in this life? Is it in the laryngopharynx area, or is it anteriorly or is it posteriorly? It is posteriorly. It is, yes, you are right, posteriorly on the left side. So this is basically a hypopharyngeal lesion which is expanding anteriorly. Again, look at these vascular structures. Look at these side plates. These are parapharyngeal spaces, paralaryngeal spaces anteriorly, parapharyngeal spaces posteriorly. So these should be very black, clean areas. There shouldn't be anything grey interposing. Look at this part. It's very black. Look at here. There are two contralateral lymph nodes, very small, but they're there. And you have to follow them up. And believe me, these change your management planning. मुसलसल एनडीटी में हम यही देखते हैं, they change your management planning completely. Now this is a coronal section that, oh sorry, I'm so sorry, this is a sagittal section, and this is a key to understanding the anatomy. What may that be? Sphenoid ठीक है, this is sphenoid sinus. Look at this normal buccopharyngeal fascia, so smooth thin down there. This is the base of the tongue. This is tongue. Look at tongue and the floor of the mouth. They are so closely related. Soft tissue densities. There is no fat in between, and there is so much movement that this is a very difficult area to establish. Although CT is helpful because it overcomes movement, but MRI is better for differentiation in the subtle densities. So this is the epiglottis. Okay, this is the hyoid bone. This is ये क्या हो सकता है? Cords. And this, so this area up till here, this should be this is, and this is laryngopharynx. Okay. So and again, now starting from there, which is this area? Yes. ये एरिएपिग्लॉटिक फोल्ड्स तो साइड में होते हैं ना बेटे, एंटीरियरली तो नहीं होंगे ज्यादा, ये एरिएपिग्लॉटिक फोल्ड है. अच्छा, then this is the supraglottic area, and this is the glottic, and this is the subglottis. So these are the areas where we concentrate upon. This is one sagittal image that you should pick. This gives such a great idea of all the images. Don't start, I always pick this central image first, then I start reading right and left to it. Okay, so this gives a perfect idea of how things are going, which area is involved, what is the superior inferior extent of the disease, and how much reconstruction you will have to do. So again, sorry I'm taking a long time, but this is a very long thing. If it is very long, then just let me stop there. Then this is basically the staging. Stage 1 limited to the organ of origin, just limited to submucosa. When it starts going into the fat adjacent, when it starts eroding the adjacent areas, stage 2, more than one area becoming longer. When it starts eroding the bone, becomes T3 like here. This is bone erosion. Okay? Anything clavus में चला जाए, cervical vertebrae में आ जाए, whatever is eroded, then paranasal sinuses तक चला जाए. Pterygoid plate तक चला जाए, then pterygoid plate right here. ये वाली. So then this would be stage 3, and obviously stage 4 is when it becomes either intracranial or it extends into the next anatomical space. Oropharynx, again I will not go into the details of it, but oropharynx lesions are mostly located in the tonsillar fossa. Again you have to look at the erosion, the mandibular erosion. Adjacent mandibular erosion is very important point. A preserved good clean fat adjacent to the lesion is important, and presence of these intact vessels is very important. These enhancing areas, peripherally enhancing areas with darkish centers, they are necrotic lymph nodes. Hypopharynx is again a difficult area, usually because it remains collapsed, and you have to look at you have to differentiate it from laryngopharynx, and sometimes it mixes up and extends very quickly into the superior esophagus as well. So a lot of classification is there, but again remember the basic points. The mucosa should be thin. If there is any asymmetry, particularly if it is enhancing and irregular, this is abnormal. If it is eroding the adjacent bone, abnormal. Always keep comparing the sides and always keep comparing both sides. And then if there is intact, clean, black space alongside it or not. And if there is anything grayish popping up into that clean black space. BUCCO-ALVEOLAR carcinoma is, oh my goodness, always coming up, one of the most common malignancies. And what you have to do is you have to diagnose, you have to give the extent, whether it has gone into the retromolar trigon or not, whether there is erosion or not, and you have always to identify, these are two different cases. This is a bone window. It's mandatory to look at the bone window, because without it you cannot identify whether the tumor has just gone up to the periosteum or has actually invaded the mandible, which requires dissection and reconstruction. So this is very important. The adjacent sulcus has to be ruled out. Again, you have to see which side is abnormal, where it is the greatest asymmetry, and what is the state of adjacent black fat alongside it, what is the state of lymph nodes, are there any lymph nodes. Laryngeal carcinoma, as I said, the key is anatomy, and the key anatomy that I just mentioned very, very salient points right here. Number one, cricoid is your key structure. Why? It is the main support. Why? Because it is the only complete frame in the whole of the laryngeal apparatus. That's why it's important. If that collapses, that is eroded, it's really, really trouble. Then the thing is, cricoid sits basically inside the thyroid. Okay. Thyroid cartilages, they are V-shaped with their spine anteriorly and their open face posteriorly. It's an inverted V. So you have to look at the thyroid cartilage, blackish areas, intact lines, they should be there. Then glottis, vocal cords should be symmetrical. Again, just alongside that, this is the anterior commissure, this is the posterior commissure. These are all clear, very, very key areas. This is the supraglottic area, this is the glottic area, and this is the hypoglottic. subglottis or a hypoglottic area. All you have to look at is asymmetry. Find out the asymmetry of the areas. You have to look at how clean are the adjacent spaces. Is the cortical, is the outline intact, outline of the cartilage intact or not? If you look at the two spaces, you can see that. You can always compare, always keep comparing. Always keep comparing. That is the key to diagnosis. Okay, look at there. Again, the focal, so please remember, if the lesion is supraglottic, then you are going to see the lymph nodes in the superior half of the neck, because it drains to the upper deep cervical nodes. Glottic, vocal tumors, vocal cord tumors. First of all, they are usually manifest early. Why? Because there is a change in the voice. Because of the change in voice, they manifest so early. Secondly, vocal cords are not vascular. Third, vocal cords do not have lymphatics. So rarely their spread is limited, and they are usually, fortunately, most fortunately, they are diagnosed early. So there is not, it has a good survival. Both the supraglottic tumors and the infraglottic tumors, they drain profusely to lymphatics and they spread early. So infraglottic goes to internal truncular, the peritracheal, then in the level 6 lymph nodes, level 6 or 7 lymph nodes होती हैं, lower half of the neck में, they become enlarged earlier. So this is again a point that may help you in looking or, okay. So critical when you are looking at the बहुत लंबी बहुत ये आपको जो क्राउन स्लाइड्स नजर आए, ये वो सारी स्लाइड्स हम देखते हैं when we are reporting CT scan. But most critical observations are, is there anterior spread, वो जो V था थायराइड का एक्सियल में, उस नॉच को तो क्रॉस नहीं कर रहा कहीं ये. That is very important. Midline तो क्रॉस नहीं कर गया, either superiorly or inferiorly, anteriorly or posteriorly, midline के क्रॉस तो नहीं कर गया. Second, is there supraglottic involvement? Or is there upper esophagus involved? Because that would change even your team as well. And is there cartilage invasion? Is there, and what is the exact location? Is it vocal cord or is it superior, inferior or laterally? Because compared to the midline vocal cord, these anterior or lateral locations, they are more dangerous lesions. As you can see in these very slides. इसमें क्या problem है? The problem is that this is, compare these two sides. There is cartilage erosion. This is hanging down, it has crossed the midline and it escaped the thyroid notch as well. Look here, cross the midline, both sides, even posteriorly. Look here, look at these spaces. So it is from these areas, look at these erosions, look at this very, very intact cartilage and look at these areas of erosion, even from outside, meaning that this is escaping and eating it from outside as well. These are the many phases of laryngeal carcinoma. This is a small tumor sitting up on the vocal cord. But again, look at this area. This is also involved. There are no lymph nodes visible, at least on this scan. But you cannot be sure until and unless you go up. Look at these things. What are these things outside? You have to compare, you have to look. Look at this thing. It looks a very clean appearance of what you had seen earlier. But there is a thickening right here in the subglottic region. Look, this is normal and look here. This is an enlarged image. So this is a subepiglottic lesion. Okay. तो ये सब देखने के लिए आपको again remember that you have to look at this. The look at this, the plane, you can see intact fat hair. The fat hair is gone. Okay. So with this, just remember the three things. Number one, CT and MRI are complementary. I'm not saying that there is no role of MRI in these cancers. There is, definitely. When you have to look at the subtle nerve involvement, when you have to see perineural spread, when you have to look at the intrinsic muscles of articulation, then yes, there is a very big role. But CT, because it's quick, it helps overcome the movement, the swallowing and the breathing artifacts. Comparing symmetry is the key. And please always use known anatomical landmarks and common sense. Thank you.